Audio, video, and presentation. Okay, so we are good to start. So it's nice to find a few familiar names, and also welcome to those whom maybe I have not met before. Today we are together and we are preparing for this PGI exam, and we are here to discuss the ophthalmology questions that you've taken in the test today morning. So how did you find the ophthal questions? How did you find the ophthal questions? Maybe it's difficult to isolate the ophthal questions separately. So the ophthal questions were kind of, I had purposely made them slightly difficult, and also for just because I thought that we should try and discuss some of the topics which are not routinely discussed. So I had included a few questions from some uncommon topics also. So we'll go on to the discussion, and just for those who may not know my name is Dr. Sudha Seetharam, and I am MBBS from Medical College, Kolkata, and MS Ophthalmology from Maulana Azad Medical College, New Delhi. And I am presently a consultant ophthalmologist at Lakshmi Eye Institute, which is an eye hospital in Maharashtra. And I am the author of this book, which is for postgraduate medical entrance preparation. And I have been a faculty of ophthalmology at multiple places. And presently, I am there with ADR plexus, hippocampus, etc. So let us start with the discussion. I'll come with the first question. So the first question is, and because this is PGI pattern, most of them, if not all, have more than one correct answers. So which of the following is or are true about Vogt Koyanagi Harada, that is VKH disease? So the first option, bilateral granulomatous panuveitis, multiple foci of choroiditis with tractional retinal detachment, topical steroids are the mainstay of management, Perilimbal vitiligo may be seen. It is an oculo-neuro-cutaneous condition associated with HLA B-5. So let me get a few answers. Tell me which one would you mark as correct? Is or are? There are more than one correct answers. There is more than one correct answer. Okay, I think many of you have got one option correct, but the other one I can get a few correct answers and a few not correct answers. So let me tell you what are the correct answers to this question. So the correct answers to this are 1 and 4, that is A and D. So bilateral granulomatous panuveitis is correct, and perilimbal vitiligo may be seen is correct. I will come back to this question after we discuss a little bit about VKH, and then we will try to see why the other options are not correct. Okay, so let us just go through a discussion on what VKH is, and then we'll come back to that picture. So VKH or Vogt Koyanagi Harada disease is an oculo-neuro-cutaneous disease, meaning it affects the eye, the brain, and the skin. And it is associated with HLA-DR4. HLA-DR4. So if I go back to this, the last option says it's an oculo-neuro-cutaneous condition. That's correct. Associated with HLA B-5. So this is wrong. It is not associated with HLA B-5. It is associated with HLA-DR4. Now the neurological features are tinnitus, vertigo, and encephalopathy. It is, the neurological features are tinnitus, vertigo, and encephalopathy. The cutaneous features are vitiligo, alopecia, and poliosis. Poliosis means whitening of the eyelashes. Now for the ocular features. The ocular features are bilateral granulomatous panuveitis. That is correct. So what does panuveitis mean? What do we mean by panuveitis? Panuveitis means Anterior, intermediate, and posterior uveitis all together. Correct. So it means anterior, intermediate, and posterior uveitis, all of them together. And it is granulomatous and it is bilateral. So bilateral granulomatous panuveitis is correct. So now, if it is panuveitis, obviously there is going to be an aspect of choroiditis, right? Because choroiditis is posterior uveitis. But what is important to note is that in VKH, we have what is called as multifocal choroiditis, meaning you have multiple small areas of choroiditis, which together give the appearance of panuveitis. But this multifocal choroiditis is not associated with tractional RD, because we have learned that choroiditis is associated with exudative RD, exudative retinal detachment. So multifocal choroiditis is correct. If I go back to this option number 2, multiple foci of choroiditis, this is correct. But the latter part of the option is wrong. It is not associated with fractional retinal detachment. Instead, it is associated with exudative retinal detachment. So that is why option number 2 is incorrect. Multiple foci of choroiditis associated with exudative retinal detachment. So it is a bilateral granulomatous panuveitis with multifocal choroiditis and exudative retinal detachment. And because of this constant choroiditis, the color of the fundus becomes dull yellow. And this appearance of the fundus is called as sunset glow fundus. This also is asked as a separate MCQ. Where is sunset glow fundus seen? This sunset glow fundus is the result of chronic choroiditis, because the choroiditis lasts for a long period of time. That is why you get this dull yellow colored fundus, which is called as sunset glow fundus. And one unique and peculiar feature of VKH disease is that it is associated with perilimbal vitiligo. That is, the area around the limbus suffers from whitening. And this perilimbal vitiligo also has a name which may be asked in exam. It is called as Suguira's sign. It is called as Suguira's sign. So perilimbal vitiligo is correct. What we need to do is we need to memorize the name of the sign. That is Suguira's sign. Perilimbal vitiligo, also called as Suguira's sign. I will come back to this. Let us now go back and review the question again. So bilateral granulomatous panuveitis is correct. Multiple focus of choroiditis is correct, but with exudative retinal detachment. Perilimbal vitiligo may be seen is correct. It is an oculo-neuro-cutaneous condition associated with HLA B-5 is wrong, because it is associated with HLA DR4. Now option number 3. Why are we saying that this is incorrect? Tell me. Topical steroids is the mainstay of management. Why are we saying that this is wrong? Why are we saying that this is wrong? Correct. It is systemic steroids and immunosuppressants which are the mainstay of management in panuveitis. In any form of panuveitis, the management should be systemic steroids and, if required, systemic immunosuppressants. So this option is also wrong. So these 3 options are incorrect. Multiple foci of choroiditis with tractional RD is wrong, because it is exudative RD. Systemic steroids are the mainstay of management along with systemic immunosuppressants, and it is associated with HLA DR4, not HLA B-5. So the correct options are 1 and 4. It's a bilateral granulomatous panuveitis, and perilimbal vitiligo or Suguira's sign may be seen. Okay, so this is about question number 1. Now, taking the opportunity of the question, let us revise a few things. Okay, tell me another condition which presents with bilateral granulomatous panuveitis. Granulomatous panuveitis is common, but bilateral granulomatous panuveitis may or may not be common. Okay, so there are 2 important conditions. I'm glad that you came up with both of them. It is sarcoidosis and sympathetic ophthalmitis. Sarcoidosis and sympathetic ophthalmitis. So we have 3 conditions where you have, commonly you have bilateral granulomatous panuveitis, sarcoidosis, sympathetic ophthalmitis, and VKH disease. BKH disease. Okay. Now tell me, where do we get Lander's sign? In which condition do we get Lander's sign? In which conditions do we get Lander's sign? Correct. Lander's sign is seen in sarcoidosis. Lander's sign is choroidal tubercles. Choroidal tubercles or granulomas. Choroidal granulomas are called as Lander's sign, and this is seen in sarcoidosis. Where do we see Dallin-Fuchs nodules? Where do we see Dallin-Fuchs nodules? Where do we see Dallin-Fuchs nodules? Correct. We see it in sympathetic ophthalmitis. This is also choroidal granulomas. So choroidal granulomas in sarcoid is called as Lander's sign. Choroidal granulomas in sympathetic ophthalmitis is called as Dallin-Fuchs nodules. They are called as Dallin-Fuchs nodules. Tell me, which type of injury gives rise to sympathetic ophthalmitis? Which type of injury gives rise to sympathetic ophthalmitis? This everybody should get correct. Right. It is penetrating injury. And penetrating injury to which part of the eye gives rise to sympathetic ophthalmitis? Penetrating injury to which part of the eye? Very good. It is the ciliary body. And hence, the ciliary body is also called as the dangerous part of the eye or the dangerous area of the eye. So penetrating injury to the region of the ciliary body gives rise to sympathetic ophthalmitis. Tell me, what is the first symptom of sympathetic ophthalmitis? First symptom of sympathetic ophthalmitis. What is the first symptom of sympathetic ophthalmitis? Now, this is very, very difficult to guess until and unless you know it. No. So please make a note of this. The first symptom of sympathetic ophthalmitis is reduced near vision due to loss of accommodation. Decrease in near vision due to loss of accommodation. Reduced near vision due to loss of accommodation is the first symptom of sympathetic ophthalmitis. And what is the first sign? This is an age-old question. I think most of you will know this. What is the first sign of sympathetic ophthalmitis? What is the first sign of sympathetic ophthalmitis? It is a retrolental flare. Retrolental flare. That is flare or turbidity just behind the lens. Just behind the lens. Flare means turbidity. Retrolental means just behind the lens. So penetrating injury to the region of ciliary body causes sympathetic ophthalmitis. Number 2, earliest symptom is loss of accommodation leading to difficulty in near vision. Earliest sign is retrolental flare, that is turbidity behind the lens. It is a bilateral granulomatous panuveitis. An important sign we just discussed to remember is Dallin-Fuchs nodules. Dallin-Fuchs nodules. Dallin-Fuchs nodules. Okay, so much about sympathetic ophthalmitis. Now, a few more MCQs from this chapter on uveitis, just in case it comes. Tell me, where do we get sauce and cheese retinopathy? Sauce and cheese retinopathy. Sauce and cheese retinopathy. Very good. It is seen in cytomegalovirus retinitis. It is seen in cytomegalovirus retinitis. Sauce and cheese retinopathy, which is seen in cytomegalovirus retinitis. Correct. The other name for sauce and cheese retinopathy is pizza pie retinopathy. The other name is pizza pie retinopathy. And there is also another name. There is a third name also. The third name is brush fire retinopathy. Brush fire retinopathy. So pizza pie retinopathy, sauce and cheese retinopathy, brush fire retinopathy, they are all names of cytomegalovirus retinitis, which is a feature of advanced HIV infection. Now listen to this question and tell me, what is the earliest ocular feature of HIV infection? Earliest ocular manifestation of HIV infection. Earliest ocular manifestation of HIV infection. Good. It is cotton wool spots. Cotton wool spots. Cotton wool spots are the earliest manifestation of HIV in the eye. Cotton wool spots are the earliest manifestation of HIV in the eye. Tell me, in which condition do we get headlight in fog appearance? Headlight in fog appearance. Headlight in fog appearance. Correct. I think all of you got it right. It is seen in toxoplasmosis. It is seen in toxoplasmosis. Right. So these are a few important things which we had to discuss in under uveitis. So if I go back to this question, as I told you, bilateral granulomatous panuveitis is correct. Multiple foci of choroiditis, but with exudative RD. Systemic steroids are the mainstay of management, followed by immunosuppressants. Perilimbal vitiligo may be seen, which is called as Suguira's sign, and it's an oculo-neuro-cutaneous condition associated with HLA DR4. HLA DR4. An important thing to remember, which you may not know, is these two names, Suguira's sign and sunset glow fundus. Suguira's sign and sunset glow fundus. Okay, so this is question number 1. Let's go to the next question. Which of the following statements is or are not true? Not true about SO palsy left. Left SO palsy. Left hypertropia with intorsion. Left hypertropia which increases in right gaze and left tilt. Millard Gubler syndrome may be associated. Difficulty in reading is a feature, and Park's 3-step test is used in diagnosis. So chalo, let's get a few answers first, then I will tell you. Which are the ones which are incorrect? For left SOP, which are the ones which are incorrect? I think one option everybody got right. But the second option, few people got right and few people did not get right. Okay, let me tell you the answer. The answer is 1 and 3. 1 and 3. So let's look at the first option. In left superior oblique palsy, the first option says left hypertropia with intorsion. What is wrong in this option? What is wrong in this option? Left hypertropia with intorsion? Correct. The answer is in left SO palsy, I should get left hypertropia with extorsion, because superior oblique, the primary function of superior oblique is intorsion. So if there is a superior oblique palsy, I will not get intorsion, rather I will get extorsion. So this is wrong. So I should get left hypertropia with extorsion and not intorsion. Right? Now this left hypertropia, it increases in right gaze and left head tilt. This is a feature of SO palsy. It increases. So if I have, say, left hypertropia. So if I have, say, left hypertropia is going to increase in the opposite gaze and same-sided head tilt. And because it increases in the same-sided head tilt, what is the head posture for SO palsy? What is the head posture for SO palsy? What is the head posture for superior oblique palsy? It is head tilt to the opposite side. Very good. So now, if suppose somebody has SO palsy on the left side. So this is left SO palsy. So if this eye is already extorted, if I tilt my head this way, the extorsion will increase. So this hypertropia and extorsion increases on same-sided tilt and it improves on opposite-sided tilt. So that is why there is a head tilt to the opposite side. So left hypertropia increasing in right gaze and left tilt is correct. Okay. Now this option, difficulty in reading is a feature. Difficulty in reading is a feature because superior oblique is mainly a depressor. So because the depressor is paralyzed, that is why there is problem in down gaze. So difficulty in reading will be a feature, right? So I will just go over option number 2 and 4 once more. In SO palsy, there is hypertropia with extorsion. So the eye is elevated and it is rotated outwards. So there is there is hypertropia with extorsion. Now, because there is hypertropia and extortion, that is why when you look to the opposite side or when you tilt your head to the same side, the diplopia worsens. Hence, to overcome mainly this extortion, the head posture is head tilt to the opposite side. And because the superior oblique is mainly a depressor, that is why the diplopia is also increased in down gaze, and hence the patient has difficulty in reading. So option number 4 and 2 are correct. Okay. Now let us come to this option. Millard Gubler syndrome may be associated. This is wrong. Why it is wrong? Because Millard Gubler is associated with nerve palsy. Correct. It is associated with 6th nerve palsy. So what is Millard Gubler syndrome? What is Millard Gubler syndrome? What is Millard Gubler syndrome? Millard Gubler is 6th nerve plus 7th nerve palsy on the same side with contralateral hemiplegia. With contralateral hemiplegia. So 6th and 7th nerve palsy with contralateral hemiplegia is Millard Gubler. It doesn't have anything to do with 4th nerve palsy or SO palsy. So Millard Gubler syndrome is a feature of 6th and 7th nerve palsy. So 6th and 7th nerve palsy with contralateral hemiplegia is Millard Gubler syndrome. And hence this option is wrong. The last option. Park's 3-step test is used in diagnosis. This is correct. Park's 3-step test or Bielchowski test. Please make a note of these names. Park's 3-step test and Bielchowski test. These are the tests used to diagnose 4th nerve palsy or SO palsy. So these are the names of the clinical tests. Park's 3-step test or Bielchowski test. So Park's 3-step test or Bielchowski test, these are the tests that are used to diagnose 4th cranial nerve palsy or SO palsy. And hence, if I go back to the question, the first option is wrong. We just discussed left hypertropia with intorsion because it should be left hypertropia with extorsion. Option 3 is wrong because Millard Gubler syndrome is associated with 6th and 7th nerve palsy, not 4th nerve palsy. The other options are correct. Left hypertropia increases in right gaze and left head tilt, and hence the head posture is head tilt to the opposite side. Difficulty in reading is a feature because superior oblique is mainly a depressor. So the paralysis of the depressor gives rise to difficulty in down gaze. Park's 3-step test and Bielchowski test are the clinical tests. Park's 3-step test and Bielchowski test are used for diagnosis of SO palsy. Now, there is a question which has come up, which I thought would come up, that left hypertropia and increases on left tilt is okay because this hypertropia and extorsion is increased on the same-sided tilt. Why does it increase on opposite gaze? Correct? Why does it increase on opposite gaze? For this, you have to just go back and think and tell me what are the functions of superior oblique. Chalo, let's revise this. Then I will discuss option number 2. What are the functions of superior oblique? Intorsion, correct. Then depression and abduction, correct. The functions of superior oblique are intorsion, depression, and abduction. So superior oblique is itself an abductor. But please listen to this carefully. The depression action of superior oblique is best in adduction. The depression action of superior oblique is best in adduction. Now let me tell you what this means. Now, suppose I have to perform this movement, that is dextroversion. Tell me what are the yoke muscles? Tell me what are the yoke muscles in dextroversion? What are the yoke muscles for dextroversion? Easy. Right-sided lateral rectus, left-sided medial rectus. Correct. Now just think and tell me for dextrodepression, which are the muscles? For dextrodepression. For dextrodepression, which are the muscles? Right-sided inferior rectus, left-sided superior oblique. Very good. Very good. Right-sided inferior rectus, left-sided superior oblique. Correct? Now please listen to me carefully. So when I am doing a movement, depression movement to the right side. So when I am doing dextrodepression, that is a depression to the right side, the muscle acting on my left eye is the superior oblique. Correct? So this means that the function of superior oblique, the depression action of superior oblique is most pronounced in the opposite gaze, right? When I'm doing a depression on the opposite side, that is when my superior oblique works best. So the depression action of superior oblique is most pronounced when this eye is adducted, that is on the opposite gaze. So that is why this left hypertropia will increase in right gaze. So when I am trying to depress my eye to the other side, that is when this left hypertropia will increase. So for this, we have to understand that the superior oblique is a depressor and the depression action is most pronounced in adduction. That means in the opposite gaze. So this left hypertropia will increase in opposite gaze because the superior oblique depression function is most pronounced in adduction. Okay, so left hypertropia is it increases in right gaze and also in left head tilt. That is why we have a head tilt to the opposite side in SO palsy. If you don't remember all this, just remember that the diplopia, it increases in opposite gaze and same-sided tilt. Diplopia in SO palsy increases in opposite gaze and same-sided head tilt. So that is why these two options are wrong. The rest of the options are correct. Okay, let's go to the next question. This is an easy question. Which of these field defects may be associated with a lesion in optic chiasma? Which of these may be associated with a defect in optic chiasma? May be associated. It doesn't mean it's always associated. It may be associated with a defect in optic chiasma. Okay, I think many of you did not get this right. These are the two answers, 1 and 2. You may very, very rarely have a binasal hemianopia, and you may have a bitemporal hemianopia, which is descending. So homonymous hemianopia, junctional hemianopia, and pie in the sky, you are not going to have with lesions in the optic chiasma. Now let me tell you how. For this, let's go back to this. Now we know that in the optic chiasma, the nasal fibers cross over, the temporal fibers continue on the same side. So if you have a lesion at the center of the optic chiasma, what will you get? If I have a lesion at the center of the optic chiasma, what will I get? Yes, I think everybody knows this. We will get a bitemporal hemianopia. Yeah, we will get a bitemporal hemianopia. Now let me take this a little further. Tell me what are the two tumors which affect the optic chiasma? The center part of the optic chiasma is mainly affected by two tumors. Tell me the names of those two tumors. Very good. Pituitary adenoma or any tumor of the pituitary gland. And the second one. Pituitary adenoma is easy. Tell me the other one. Yes, it is craniopharyngioma. Very good. So you have pituitary adenoma and you have craniopharyngioma. Now here, please listen to me carefully. There is a difference in which the pituitary adenoma and the craniopharyngioma affect the optic chiasma. The pituitary adenoma affects it from below. The pituitary adenoma is below the chiasma. So it affects the chiasma from below. Whereas the craniopharyngioma, it affects or touches the chiasma from above. Okay. So now when the pituitary adenoma grows, it first comes in contact with the inferior nasal fibers, right? Now tell me, is the slide visible? Is my slide visible? And is my voice audible? Okay. So now, see, when the pituitary adenoma enlarges, it touches the chiasma from below. So when it touches the chiasma from below, this means that it first touches the inferior nasal fibers, right? Now just think and tell me, inferior nasal fibers are responsible for which field? Inferior nasal will be responsible for the, very good. So superior temporal field. So when you have a pituitary adenoma, in the early stages, this bitemporal hemianopia will begin from above. So it will look something like this. So you have a bitemporal hemianopia, which is beginning from above. So this is called as a descending bitemporal hemianopia. Now, as the pituitary adenoma enlarges, it will become a complete bitemporal hemianopia. But in the early stages, because the pituitary adenoma is touching it from below, that is why the inferior nasal fibers are affected, which means that you will get a bitemporal hemianopia beginning from above. So that is called as a descending bitemporal hemianopia. Sorry. Thank you for the correction. I made a mistake. It should look something like this. So it should look like this, a descending bitemporal hemianopia. So a descending bitemporal hemianopia, that is a bitemporal hemianopia which begins from above. So the inferior nasal fibers are affected first, resulting in a descending bitemporal hemianopia. So descending bitemporal hemianopia is a feature of early pituitary adenoma. It's an early feature of pituitary adenoma. Now, by the same logic, tell me what will happen to a craniopharyngioma? Craniopharyngioma touches from above. So what kind of bitemporal hemianopia will I get? What kind of hemianopia will I get? Very good. I will get an ascending bitemporal hemianopia. So you can make a note of this. Pituitary adenoma gives rise to descending bitemporal hemianopia, and craniopharyngioma gives rise to ascending bitemporal hemianopia. Descending means the bitemporal hemianopia starts from above and gradually comes down. And ascending means the bitemporal hemianopia begins from below and gradually moves up. Eventually, it will become a complete bitemporal hemianopia. But in pituitary adenoma, it will begin from above, so it's called as descending. And in craniopharyngioma, it will begin from below, so it's called as ascending. So this option is correct. That is option number 2. That is descending bitemporal hemianopia. Now let me come to binasal hemianopia. This is a very, very rare condition, but it may still happen. It happens if there is a mass which is affecting only the lateral part of the optic chiasma. It happens very, very rarely when only this and these fibers are affected, and a mass which is affecting only the lateral fibers of the chiasma and the central part is spared. So the temporal fibers of both eyes will be affected, and you end up with a binasal hemianopia, which looks something like this. So you may end up with a binasal hemianopia, which looks something like this. So it's very, very rare, but it is possible. So bitemporal hemianopia, both ascending and descending, is possible in chiasma lesion. Binasal hemianopia is also possible, very, very rarely, in optic chiasma lesion. So the answer is 1 and 2. The answer is 1 and 2. Okay. Now let us just go through the other option. Tell me, where do we get homonymous hemianopia? Where do we get homonymous hemianopia? We mainly get it in lesion of the optic tract. Where do we get pie in the sky? Where do we get pie in the sky? Where do we get pie in the sky? Yes, it is lesion in the temporal lobe or lesion in the Mayer's loop. Correct. Lesion in the temporal lobe or the Mayer's loop. Now, can anybody tell me where we will get junctional scotoma of Trachwire? I will explain this, but just to see if you know the answer. Where do we get junctional scotoma of Trachwire? Correct. I have got a few correct answers. Let me just explain this to you once. Now, if you look at this picture, this junctional scotoma of Trachwire is seen when you get a lesion in this posterior end of the optic nerve that is here. Somewhere in the posterior end of the optic nerve, if you get a lesion, you get a junctional scotoma of Trachwire. Now, let me tell you what this is. Now, basically, what happens is, suppose this is one eye, this is the other eye, right? The nasal temporal fibers, nasal temporal fibers. The nasal fibers, we know, they cross over, and the temporal fibers, they go on the same side. Now, this nasal fibers, the lower nasal and the upper nasal fibers are like split. So let me just draw it like this. The lower nasal and the upper nasal. The lower nasal fibers, what they do is, they form a loop like this into, sorry, just so I'll just draw it like this, the lower nasal and the upper nasal fibers. The lower nasal fibers, they form a loop like this into the optic nerve, and then they enter the optic tract. The upper nasal fibers, they don't form this loop. So like this, and then they enter. So let me go over this once more. We know that at the level of the optic chiasma, the nasal fibers, they cross over and they enter the optic tract of the opposite side. But these nasal fibers also are split into lower nasal and upper nasal. Okay. Now the lower nasal fibers, they form a loop into the optic nerve of the opposite side, and then they enter the optic tract. And this loop that they form, this has a name. It is called as Willebrand's knee. It is called as Willebrand's knee. To be more precise, it is called as von Willebrand's knee. It is called as von Willebrand's knee. Now, suppose you have a lesion somewhere in the posterior part of the optic nerve. In the posterior part of the optic nerve, if I have a lesion, then just think and tell me what is the defect that I will get. Tell me what is the defect that I will get if I get a lesion in the posterior part of the optic nerve. On the same side, what will I get? On the same side, what is likely to be to get? Yes, I can get an ipsilateral total scotoma. Correct. I will get an ipsilateral total scotoma or blindness. But if the optic nerve is not affected completely, then instead of getting a total scotoma, what I will get is a centrocecal scotoma, because total scotoma starts centrally. So in the early stages, I may not get a total scotoma because of optic nerve lesion. I will get a centrocecal scotoma. In the advanced stages, I will get a total scotoma. But in early stages of optic nerve lesion, I get a centrocecal scotoma. So on the same side, I get a centrocecal scotoma or a total scotoma. On the other side, what will I get? On the other side, what will I get? If the lower nasal fibers are affected on the other side, what will I get? Correct. I will get an upper temporal field defect. Right? I will get a superotemporal field defect. So this is called as junctional scotoma of Trachwire. This is called as junctional scotoma of Trachwire. So this is called as junctional scotoma of Trachwire. So if we are asked what is junctional scotoma of Trachwire, it is basically centrocecal scotoma or total scotoma on the same side. and superotemporal hemianopia on the other side. I will repeat this. So junctional scotoma of trachwire means centrocecal scotoma or total scotoma on the same side with superotemporal hemianopia on the other side. And all this is because the Willebrand's knee is affected. Okay, so if this Willebrand's knee is affected in the posterior part of the optic nerve, we end up with junctional scotoma of trachwire, which is a combination of centrocecal scotoma or total scotoma on the same side and superotemporal hemianopia. Right? Now I'll ask you a tough question for which you have to think and answer. This posterior part of the optic nerve, would you call it the distal part of the optic nerve or the proximal part? This is a very common mistake. Think and say. Would you call it the distal part of the optic nerve or the proximal? I have few correct and few wrong answers. It is proximal. It is not distal. Why is it proximal? Because it is closer to my body. Distal means something which is away from my body. The optic nerve starts from the eye and it comes towards the CNS, right? So the part which is closer to the CNS is actually the proximal part. So the posterior part of the optic nerve is the proximal part of the optic nerve. It is not the distal part of the optic nerve. This is a very, very common mistake that we make when we are asked junctional scotoma is caused by. The answer is junctional scotoma is caused by lesion in the proximal part of the optic nerve or the posterior part of the optic nerve. So junctional scotoma of trachwire, this is caused by lesion in the proximal part of the optic nerve or the posterior part of the optic nerve. Okay? So homonymous hemianopia for optic tract, junctional scotoma of trachwire for posterior part or proximal part of the optic nerve, pie in the sky for lesion in the Mayer's loop or temporal lobe. And the other two are for lesion in the optic chiasma. So what did we learn? Descending bitemporal hemianopia is caused by pituitary adenoma, and ascending bitemporal hemianopia is caused by craniopharyngioma. Correct. Pie on the floor is caused by lesion in parietal lobe. And what is the field defect for lesion in the occipital cortex? Lesion in the occipital cortex causes homonymous hemianopia with macular sparing, correct, with central sparing. And this sparing is due to sparing of which artery? This sparing is due to the sparing of which artery? Correct. It is the middle cerebral artery, but the main blood supply to the occipital cortex is the posterior cerebral artery. The main blood supply is the posterior cerebral artery. Okay. Now question number 4. This is a difficult question. Question number 4. This is about corneal ectasias, which is not commonly discussed. That's why I gave this question. Okay. So first tell me what is corneal ectasia. Let's start from there and then I'll take the question. What is corneal ectasia? What is corneal ectasia? Ectasia means not only thinning. Thinning is one part. The other part is very good, protrusion. So there has to be protrusion of the cornea and there has to be thinning. Together, if both these things are present, that is when we will call it as ectasia. Okay. So before I come to the question, can you tell me what are the 3 corneal ectasias that we have? The non-inflammatory corneal ectasias. What are the 3 non-inflammatory corneal ectasias? One all of us know, that is keratoconus. There are other 2, keratoglobus and pellucid marginal degeneration. Keratoglobus and pellucid marginal degeneration. So there are basically 3 types of non-inflammatory corneal ectasias: keratoconus, keratoglobus, and pellucid marginal degeneration. An ectasia by definition is protrusion associated with thinning. Now keratoconus, all of us know. The other 2 Many of us may not know. I'll discuss that. Let me just revise what is keratoconus. Keratoconus, if I depict this pictorially, it will look something like this. So only, excuse me. If I depict keratoconus, it will be something like this. So one small part of the cornea is protruded and it is also thinned out. So one small part of the cornea is protruded and thinned out, and that is called as keratoconus. So this part which is protruded and thinned out, this is called as keratoconus. Okay. So one small part of the cornea is protruded and thin. And hence, because only one small part of the cornea is protruded and thin, what is the refractive error in keratoconus? What is the refractive error that we see in keratoconus? Because only one small part is protruded. Correct. Irregular myopic astigmatism. Very good. Myopic astigmatism, which is irregular. A few easy questions now. At the base of the cone in keratoconus, a pigmented line is seen. What is that line called? Pigmented line at the base of the cone in keratoconus. Pigmented line at the base of the cone in keratoconus. It is called as Fleischer's ring. And this Fleischer's ring is due to deposition of, this Fleischer's ring is caused by deposition of, very good, it is caused by the deposition of iron. It is caused by deposition of iron. Now, when the patient looks down, the protruded cornea indents the lower lid. What is this called? What is this called? Very good. It is called as Munson's sign. It is called as Munson's sign. So when the patient looks down, the protruded cornea presses the lower lid. That is called as Munson's sign. At the base of the cone here, we have a pigmented line that is Fleischer's ring. Now, there are stretch lines which are formed on the Descemet's membrane of the cornea. What are they called? What are they called? In keratoconus, stretch lines on the Descemet's membrane are called as, very good, they are called as Vogt striae. And can you tell me what is the direction of the Vogt striae? Yes, easy to remember, V for V. Vertical is the direction of the Vogt striae. And if there is a tear of the Descemet's in keratoconus, what is that called? Tear of the Descemet's in keratoconus, that is called as hydrops. Correct. That is called as hydrops. So keratoconus, all of us study and study it well. So there are most of the things about keratoconus we know, except for one thing which I find that students often miss to learn, that is the associations of keratoconus. Keratoconus is associated with these few very important conditions. So please make a note of this. It is associated with VKC, Downs, Marfan, and Ehlers-Danlos syndrome. These are important associations of keratoconus. VKC, Down syndrome, Marfan, and Ehlers-Danlos syndrome. Okay, so these are important associations of keratoconus. And all of us know that the first line of management for keratoconus is RGP contact lenses. RGP contact lenses, because they help to correct what? What do they help to correct? The RGP lenses. What do the RGP lenses help to correct? They help to correct the irregular astigmatism. They help to correct the irregular astigmatism. That is why RGP lenses are used in the treatment of keratoconus. Now, if the RGP lenses, you are not able to fit the RGP lens in a keratoconic patient, what is the procedure that you do? What is the procedure that we do? Procedure that is done? Very good. That is called as C3R. C3R stands for corneal collagen cross-linking. Corneal collagen cross-linking. Corneal collagen cross-linking. So first line of management is RGP lens. Second line of management is corneal collagen cross-linking, that is C3R, which helps to flatten the cornea. And what is the last line of management? Last line of management is keratoplasty, which means cornea transplantation, keratoplasty. So in advanced cases, I will go for keratoplasty. Any ectasia in the advanced stage, there is nothing else you can do except keratoplasty. So for keratoconus, RGP lens, C3R, keratoplasty. Okay. So keratoconus is one ectasia that we do read. What we don't read are the remaining two, which I'm going to tell you. That is keratoglobus. Now the difference between keratoconus and globus is that in globus, the whole cornea is protruded and thin. So the whole cornea, it looks something like this. If I draw the cornea, it will look something like this. So the whole cornea is protruded and thinned out, and sometimes it is so thin that there is a risk of corneal rupture. So if the whole cornea is protruded and thin, unlike in K conus where only a small part is protruded. So now if the whole cornea is protruded and thin, what is the refractive error you expect? It is uniform. The whole cornea is protruded. So what is the refractive error you will expect? We expect a high myopia because the entire corneal surface is protruded. So the refractive error here is high myopia, and because of extreme thinning, this is associated with risk of corneal rupture. Okay, the associations of this are osteogenesis imperfecta and Leber's congenital amaurosis. Osteogenesis imperfecta and Leber's amaurosis are associations of keratoglobus. Now for the treatment. For keratoglobus, you give contact lenses, but these are large diameter contact lenses because the whole cornea is so much protruded. A regular contact lens will not fit. A large diameter contact lens which sits on the sclera, that is the management for keratoconus. They are called scleral contact lenses. So as I told you, in keratoconus, it is RGP lens. For keratoglobus, it is scleral contact lens. Second line of management in advanced cases is keratoplasty. So scleral contact lens and keratoplasty is the management for keratoglobus. So in keratoglobus, the whole cornea is thinned out and protruded. There is high myopia, risk of corneal rupture, scleral contact lens and keratoplasty. Association, osteogenesis imperfecta and Leber's amaurosis. Okay, this is the second of our ectasias. The third one is the trickiest. It is called as pellucid marginal degeneration. Pellucid marginal degeneration. Now let me tell you what is pellucid marginal degeneration. Now in pellucid marginal degeneration, it is a very different or unique type of ectasia where it affects. This is here, the protrusion is there, and then just below the protrusion will be the area of thinning. The protrusion is usually in the inferior part of the cornea. Sorry, just write it again. The protrusion is usually in the inferior part of the cornea. So this is the area of protrusion. This peak is the area of protrusion in the lower part of the cornea. But the thinning is not at the area of protrusion, but just beneath it. The area of thinning is here, which is just beneath the area of protrusion. So this green part is the area of protrusion, and this blue part is the area of thinning. I will just repeat it once more. See, basically in keratoconus, you had a protrusion and the protruded area itself was the thinnest part, correct? In keratoglobus, the whole cornea was protruded and the whole cornea was thin. In pellucid, the area of thinning and the area of protrusion are not the same. The area of protrusion is just above the area of thinning. So in the inferior part of the cornea, there is an area of thinning here. But the area of protrusion is just above the area of thinning. So this part that I have shown in green is the area of protrusion. So you have an area of protrusion, and just beneath the area of protrusion, you have an area of thinning. And all this is located in the lower half of the cornea. So what are the features of pellucid? Pellucid, it affects the inferior part of the cornea. There is a band of corneal thinning from 4 o'clock to 8 o'clock. So in the lower part of the cornea, from 4 o'clock to 8 o'clock, there is an area of thinning. And just above it is the area of protrusion. So the protruded cornea lies just superior to the band of thinning. So this is its difference from K conus. In K conus, the area of thinning is the same as the area of protrusion. In pellucid, the area of thinning lies just below the area of protrusion. So the area of protrusion is above and the area of thinning lies just below it. Okay. It also presents with irregular myopic astigmatism and RGP lens is the treatment. Irregular myopic astigmatism, RGP lens is the treatment. In advanced case, here also you have to go for keratoplasty. Here also you go for keratoplasty. Okay, so I'll just go over this once more. Pellucid affects the lower part of the cornea. The area of thinning is just below the area of protrusion. Irregular myopic astigmatism is seen. RGP contact lens is the first line of management. Keratoplasty is the management for the advanced stage. For none of these ectasias, no particular etiology is known. For keratoconus, globus, and pellucid marginal degeneration, no accepted etiology is known till now. So these are our three non-inflammatory corneal ectasia. Okay, so let's just go over this once more. So now tell me there are no particular associations to PMD. There are no particular associations to PMD. So let's just go over the questions. So what are the correct options here? What are the correct options here? Pellucid marginal degeneration involves the superior cornea. This is wrong. This is wrong. Keratoglobus is associated with severe corneal thinning and myopia is correct. Fleischer's ring is seen in keratoconus is also correct. Keratoplasty is the treatment in advanced cases. This is also correct. VKC is a common association of K conus is also correct. So 2, 3, 4 and 5. These are the correct options. 2, 3, 4 and 5. These are our correct options. So the only wrong option is this one. That is pellucid involves the superior cornea. Because what should be the correct answer? Pellucid involves which part of the cornea? It involves the inferior cornea. It involves the inferior cornea. Okay. Now question number 5. Causes of intraocular calcification is or are PHPV, Stargardt's, retinoblastoma, optic nerve head drusen, hypertensive retinopathy. Okay, so what are the correct answers? This is something to memorize, nothing to understand. I will just give you the list. The answers are 3 and 4. Retinoblastoma and optic nerve head drusen. So this is an old question from PGI itself. So we have to memorize this. Intraocular calcification. The important causes are retinoblastoma, optic nerve head drusen, choroidal osteoma, choroidal angioma, toxoplasmosis, Coats disease, ROP, thysis bulbi, and systemic hypercalcemia. So retinoblastoma, optic nerve head drusen, choroidal osteoma, choroidal angioma, toxoplasmosis, Coats disease, ROP, thysis bulbi, and systemic hypercalcemia. These are the causes of intraocular calcification. Retinoblastoma, optic nerve head drusen, choroidal osteoma, choroidal angioma, toxoplasma, Coats disease, ROP, thysis bulbi, and systemic hypercalcemia. Okay. So let's come to the next question. This again is a very rarely discussed topic. That's why I wanted to put this question. Pseudo-exfoliation syndrome, true, is or are? Secondary angle closure glaucoma, extracellular amorphous material secreted by corneal endothelium, Sampaolese line may be seen, zonular weakness with subluxation of lens is a feature, and it's always unilateral. Tell me which are the ones which are true. Which are the ones which are true? Some correct answers I'm getting, but some are not. Okay, so I'll just go over to the correct answers. Answer is 3 and 4. Sampaolese line may be seen and zonular weakness is a feature. Okay, let me tell you why the other options are wrong. The first one, why is it wrong? Why is it wrong? Secondary angle closure glaucoma, because pseudoexfoliation causes secondary open angle glaucoma. The exfoliative material gets deposited in the trabecular meshwork and blocks its pores. So there is no closure of the angle. The pores of the trabecular meshwork are blocked. So it is an open angle glaucoma, not angle closure. Second one, what is this exfoliative material? This exfoliative material is not produced by the corneal endothelium. It is produced by whom? Who produces this pseudo-exfoliative material? Correct. It is produced by the lens epithelium. So it is produced not by the corneal endothelium, but by the lens epithelium. So that is wrong. Sampaolese line, this is a pigmented line seen in the trabecular meshwork. It is seen in pseudoexfoliation. It's the pigmented line at the trabecular meshwork. And zonular weakness is a feature of pseudoexfoliation. I will come to the features of PXF. It may be unilateral or bilateral. It is sometimes unilateral, sometimes bilateral. There is no rule. So this is also wrong. So 3 and 4 are our correct options. So let me just quickly go over the features of PXF. In PXF, as I told you, it is produced by the lens epithelium. Deposition in the angle gives rise to Sampaolese line. Deposition in the zonules gives rise to lens subluxation. Deposition at the pupillary margin gives rise to poor mydriasis. So you have a poorly dilating pupil. And you may have a PXF ring on the lens capsule. So you may have a PXF ring on the lens capsule. I'll just show you a picture. See, this is the PXF ring on the lens capsule. On the lens capsule, when it is deposited, you get a line, a ring which looks like this. And here at the margin of the pupil, you can see these whitish deposits. They give rise to poor mydriasis. So PXF ring on the lens capsule, poor mydriasis due to deposition in the iris. You have lens subluxation and Sampaolese line. These are the features of PXF. Okay, so the correct options are 3 and 4. Sampaolese line may be seen, zonular weakness may be seen. Okay, next question. This again is a topic which is less discussed. In duochrome, Sampaolese line is a pigmented line in the trabecular meshwork. Pigmented line in the trabecular meshwork. Question number 7. Untrue statements, that is false statements about refraction are. In duochrome test, if red letters are clearer than green, it indicates hypermetropia. Myopes should be overcorrected. Improvement in visual acuity with pinhole indicates macular pathology. Jackson's cross cylinder is used to refine cylindrical correction. Phoropter is used for the analysis of or evaluation of refractive error. Okay, this I think very few people have got right. The untrue statements are 1, 2, and 3. 1, 2, and 3. Now, what is duochrome test? You may have seen that in our Snellen's chart at the bottom of it, there is one red band of letters and one green band of letters. Okay. So if you ask the patient to read this, and if he reads the red correctly, what does it mean? And if he reads the red better, what does it mean? If he reads the green better, what does it mean? Now, if you look at this picture tells you that there is a difference in refraction between the red and the green rays. Now, the green rays, they meet somewhere here. This is a normal sized eyeball. So in a normal sized eyeball, the green rays meet here and the red rays meet here. So now tell me, if somebody sees the red rays better, that means that his retina is somewhere here. So what does it indicate? He's myope or hypermetrop? What does it indicate? It indicates that he is myope because his eyeball is larger. And if somebody sees green better, it means that his retina is somewhere here, which means that if somebody sees green better, he is hypermetrop. If somebody sees red better, he is actually a myope. Okay? So the first option is wrong. In duochrome test, if red letters are clearer, it indicates myopia. It doesn't indicate hypermetropia. If your red letters are clearer, it indicates myopia, not hypermetropia. Second, myopes should always be overcorrected. This is wrong because myopes should be always undercorrected. Myopes should always be undercorrected. Why should we undercorrect myopes? Because in myopia, the distant vision is poor, but the near vision is very good. Right? The near vision is good in myopes. The distance vision is poor. So you should leave myopes slightly undercorrected. Then near vision will be very good with slightly undercorrected myopia. But if you overcorrect them, then what happens? If you overcorrect a myope, he becomes a hypermetrop. And then he starts having difficulty both in distant and in near vision. So you should never overcorrect a myope. Myopes should always be undercorrected. Because if you leave them undercorrected, their near vision remains very, very good. So myopes should always be undercorrected. Okay. The third option, a pinhole. Now let me tell you what is a pinhole. Now see, a pinhole is something like this. There is a disc like this, and at the center there is a small aperture, which is about 1 mm in diameter. And if you give a patient this pinhole and you ask him to read the Snellen's chart, first you ask him to read the Snellen's chart without the pinhole, then you ask him to read the Snellen's chart with the pinhole. If his visual acuity improves, then it indicates that there is a refractive error. If the visual acuity improves, it indicates a refractive error. And if it becomes worse, it indicates that there is a lesion in his macula, because the macula is at the center. So with the pinhole, in case of a macular disease, the visual acuity will worsen. So worsening indicates a macular pathology and improvement indicates a refractive error with a pinhole. So with a pinhole, if my visual acuity is improving, it means that I have a refractive error. And if it is worsening, it means that I have a macular pathology. Okay, so if I look at this option, it means that improvement in visual acuity with pinhole indicates macular pathology is wrong. It means that he has a refractive error. Now the last two options. Jackson's cross cylinder is used to refine cylindrical correction. Now this is what a Jackson's cross cylinder looks like. It is a combination of two cylinders at perpendicular axis. So you have two cylinders, one plus, one minus. See here, you have one small plus cylinder and you have one small minus cylinder at perpendicular axis. And this instrument helps to refine your cylindrical correction. It helps to refine the amount, the power, as well as the axis of your cylindrical correction. So Jackson's cross cylinder is used to refine cylindrical correction is correct. And Phoropter is used to assess refractive error is also correct. This is a new instrument for assessing refractive error. Commonly, what is the instrument for assessing refractive error? Commonly, what is the instrument? The usual instruments. What are the usual instruments? Retinoscope and what are the usual instruments? Retinoscope and And autorefractometer, correct. The common instruments are retinoscope and autorefractometer. So the common instruments are retinoscope and autorefractometer. The better instrument, the newer instrument now, I won't say better, the newer instrument now is a phoropter. So these two options are correct. Jackson's cross cylinder helps to refine cylindrical correction. Phoropter is used for refractive error. The others are wrong. So I'll just go over it once more. In duochrome test, if the person sees red color better, it means that he has a longer eyeball, meaning he's a myope. As you can see from this picture, the red light, they are focused further and green light is focused closer. So somebody who sees green letters better is a hypermetro, and somebody who sees red letters better is a myope. So in duochrome test, red better indicates myopia. Second option, myopes should always be left under-corrected so that their near vision is crisp and good. Improvement in visual acuity with pinhole indicates refractive error. With macular pathology, there will be a worsening of the visual acuity with pinhole. So improvement of visual acuity with pinhole indicates refractive error. Myopes should always be under-corrected. And duochrome test, if the red letters are better, it indicates myopia. Okay? Sure. Next question. Features of thyroid ophthalmopathy is or are. What are the features of thyroid ophthalmopathy? Non-axial proptosis. Inferior rectus muscle is first to be involved. Thyroid status may be hyperthyroid, hypothyroid, or euthyroid on presentation. Infrequent blinking is the first sign. Exposure keratopathy may be seen in severe cases. So let me get a few answers. Okay, I'm getting few correct answers. The correct options are 2, 3, and 5. 2, 3, and 5. So first tell me, why is the first option wrong? Non-axial proptosis, why is it wrong? Why is it wrong? Correct. It is an axial proptosis. It is an axial proptosis, not a non-axial proptosis. Inferior rectus is the first muscle to be involved. That is correct. Thyroid status at the time of presentation may be hyper, hypo, or euthyroid. May be hyper, hypo, or euthyroid on presentation. Exposure keratopathy may be seen in severe cases. Why? Because the eyeball, if it becomes too much proptosed, the eye will not be able to close and you may get exposure keratopathy. Infrequent blinking is not the first sign. Tell me, what is the first sign? What is the first sign? What is the first sign? The first sign, good, is lid retraction. The first sign is lid retraction. So let us learn up the signs of thyroid ophthalmopathy, which are often asked in PGI exam. So the signs are lid retraction or a Dalrymple sign, which is the earliest. Lid lag in down gaze, Von Graffi sign. Tremor of the closed lids, Rosenbach sign. And infrequent blinking, which is Stellwag sign. So lid retraction or Dalrymple sign, lid lag in down gaze, that is Von Graffi sign. Tremor of the closed lids, that is Rosenbach sign. And infrequent blinking, that is Stellwag sign. So the earliest sign is not infrequent blinking or Stellwag, it is lid retraction, that is Dalrymple sign. So these are the important signs in thyroid ophthalmopathy. And proptosis is seen, but it is axial. Restriction of ocular movements is seen, and the first muscle involved is inferior rectus. The first muscle involved is inferior rectus. So these are the features of thyroid ophthalmopathy. So just quickly to revise, tell me, what is What is the treatment for thyroid ophthalmopathy? What is the treatment for thyroid ophthalmopathy? Steroids, correct. Topical or systemic? Topical or systemic? It is systemic steroids. So systemic steroids, systemic immunosuppressants, and radiotherapy is the treatment. Systemic steroids, systemic immunosuppressants, orbital radiotherapy is the treatment. And if you have exposure keratopathy, you can go for orbital decompression. If there is so much of proptosis that there is exposure keratopathy, you can go for orbital decompression. So steroids, immunosuppressants, radiotherapy, and orbital decompression for the active disease. And when the disease is not active, then you can go for corrective surgeries of the lids and the muscles. Corrective surgeries of the lids and the muscles, they are done in the inactive stage. But the main treatment is for the active stage, that is steroids, immunosuppressants, radiotherapy, and orbital decompression if there is exposure keratopathy or some serious complication. Okay, next question. This also is a less discussed topic, so I thought I'll put a question on that. Correct statement about nystagmus is: optokinetic nystagmus is a physiological nystagmus. Poor vision in early childhood causes motor nystagmus. Ataxic nystagmus is seen in I and O. Direction of the slow component is the direction of jerk nystagmus. And seesaw nystagmus is seen in optic chiasma. Seesaw nystagmus is seen in optic chiasma. Okay. I'm getting a few correct answers. Let me go to the slides. Answer is 1, 3, and 5. Optokinetic nystagmus, all of you know, is a physiological nystagmus. It is a physiological nystagmus, and it is often used for visual acuity assessment in kids or infants. Poor vision in early childhood, it does not cause motor nystagmus. It causes something called as sensory nystagmus. So when there is poor vision in early childhood, you end up with sensory nystagmus, not with motor nystagmus. I will come to the slides and then I'll come back to the questions again. Now see, nystagmus is basically is of two types when you look at it clinically. One is a pendular nystagmus. Pendular nystagmus means the eye moves to one side and the other side with equal speed. This is pendular nystagmus. The other is called as a jerk nystagmus. Jerk nystagmus means one side is fast, the other side is slow. So fast, slow, fast, slow. This is jerk nystagmus. Pendular means like this. So clinically, you have these two types. Now for the jerk nystagmus, the direction of the nystagmus is named according to the fast component, not the slow. So if there is a fast component to the right, it will be called as a right-sided nystagmus. Okay, so if I get a nystagmus with a fast component to the right, I will call it a right-sided nystagmus. So the direction is named according to the fast component. Okay, now what are the types of nystagmus? Physiological. Physiological, optokinetic nystagmus, vestibular nystagmus. Vestibular nystagmus means what? If you stimulate the ear with water, then you get a nystagmus. And it is remembered, all of you know, as cows. What does cows mean? What does cows mean? Cow stands for cold opposite, warm same. Yes. If I stimulate with cold water, the direction of nystagmus will be to the opposite side. With warm water, it will be to the same side. So this is vestibular nystagmus. These three are our physiological nystagmus. End gaze nystagmus, optokinetic nystagmus, vestibular nystagmus. Then you have sensory deprivation nystagmus, which I told you, if somebody has poor vision in early childhood, it gives rise to sensory nystagmus, not motor nystagmus. Now, motor nystagmus. These four, please memorize. These are the 4 types of motor nystagmus. We don't need to know the details, but we need to know the names. Ataxic nystagmus is seen in INO. Downbeat nystagmus is seen in lesions of cervicomedullary junction. Downbeat means the fast component is down. Upbeat nystagmus means fast component is up. It is seen in posterior fossa lesions. And seesaw nystagmus. This is seen in optic chiasma lesion. So ataxic nystagmus, downbeat nystagmus, upbeat nystagmus, seesaw nystagmus. Just learn up these 4 names. Ataxic nystagmus in INO, downbeat nystagmus in lesions of cervicomedullary junction, upbeat nystagmus in lesions of the posterior fossa, and seesaw nystagmus for lesions of the optic chiasma. These are called as, these are the types of motor nystagmus. These are the types of motor nystagmus. Now, if I go back to the question, see, optokinetic nystagmus is a physiological nystagmus, is correct. Poor vision in early childhood causes sensory nystagmus. Ataxic nystagmus is seen in INO is correct. Direction of slow component is the direction of jerk nystagmus is wrong. Why? Direction of slow component is the direction of jerk nystagmus is wrong. Why? Because it is the direction of the fast component which determines the direction. And seesaw nystagmus is seen in optic chiasma lesions is also correct. Okay. So here, what you need to remember is these 4. Sensory nystagmus means which is induced because of poor sensation. Poor sensation means poor vision. Sensory deprivation nystagmus is due to poor vision in childhood. Like, for example, if a child has a macular pathology, congenital macular pathology, he will have a sensory deprivation. So learn up these 4. Motor nystagmus, ataxic nystagmus in INO, downbeat nystagmus in cervicomedullary junction lesions, upbeat for posterior fossa lesions, seesaw nystagmus for chiasma lesions. Okay. Just to recap, in vestibular nystagmus, if I stimulate with warm water, direction of fast component is to the same side. Direction of the fast component is to the same side. Correct. Sudden painless loss of vision. Sudden painless loss of vision. This I think everybody would have got it right. Tell me which of these is the sudden causes of sudden painless loss of vision. Vitreous hemorrhage, acute iridocyclitis, Stargardt's, rhegmatogenous RD, angle closure glaucoma. The answers are 1 and 4. Correct. 1 and 4. I think everybody got this right. So just to finish the discussion, acute iridocyclitis, what kind of vision loss? Acute iridocyclitis. Acute iridocyclitis. Sudden or gradual? Sudden or gradual? Sudden and painful. Sudden and painful. Acute iridocyclitis is sudden and painful. Which other one in the list is sudden and painful? Which other one in the list is sudden and painful? Correct, ACG. So acute iridocyclitis and ACG are sudden and painful. And Stargardt's is? Stargardt's disease, what kind of vision loss? Stargardt's disease, what kind of vision loss? Gradual and painless. Good. So Stargardt's, gradual and painless, acute iridocyclitis and angle closure glaucoma, sudden and painful, vitreous hemorrhage and reg RD, sudden and painless. Correct. This was an easy question. Okay. This is a question with single correct answer. This is Word's 4-dot test. What does this number 2 indicate? What does this indicate? Okay, the red is in front of the right eye. The red is in front of the right eye. The red is in front of the right eye. The green is in front of the left eye. So what does this indicate? So you can see two reds, which means that the red which is in front of the right eye is actually functioning. So which is not functioning? It is the left eye, because I cannot see any green. So it is left eye suppression. It indicates left eye suppression. Okay, so just to go over this once more, this is what the Worth's 4-dot test looks like. Red is usually on top. You have two greens and one white at the bottom. Normal person usually sees like this, or he may see this white usually as red, because the right eye is usually dominant in most people. So for a normal person, this lower light will also appear to be red. So you will see two red, two green, usually, if your right eye is dominant. If there is a right eye suppression, you will not see any red. You will see only green. If the left eye is suppressed, you will not see any green. You will see only red. And if there is diplopia, you will see 5 lights instead of 4. So 5 lights instead of 4 indicates diplopia. If you see 3 green, it means that the right eye is not functioning or suppressed. If you see 2 red, it means that the left eye is suppressed. If you see 5 lights, it means that you have diplopia. And if you see 4 lights and the lower one also appears red to you, it means that you're normal and your right eye is dominant. Okay, now tell me, if you see 4 lights and you see green at the bottom, what does it mean? If you see 4 lights with green at the bottom, it means that your left eye is dominant. This is going to happen in very few people, but it is possible. If I see 4 lights and the lower one also appears to be green, it means that I am normal, but my left eye is dominant. So the answer here is left eye suppression, because see, I can see only 2 lights which are red. I am unable to see the green. So this means that my left eye is suppressed and it's only my right eye which is functioning. So the answer is 3, that is left eye suppression. This is a very easy question. Identify the incorrect matches. Breadcrumb appearance, steroid-induced cataract, unilateral papilledema, Foster-Kennedy syndrome, Mizuo phenomenon, Oguchi, limbal dermoid in Goldenhaar, shield ulcer in flictenular conjunctivitis. This I think everyone should get right. It's this almost a neat standard question. Okay, the answer is 1 and 5. Breadcrumb appearance is not seen in steroid-induced cataract. Where is it seen? Breadcrumb appearance, where is it seen? Correct. It is seen in complicated cataract. It is seen in complicated cataract. Unilateral papilledema is seen in Foster-Kennedy syndrome. What is Foster-Kennedy syndrome? What is Foster-Kennedy syndrome? It is seen where? In which tumor is it seen? It is seen in olfactory lobe tumor. It is usually seen in olfactory lobe tumors, in which you have optic atrophy on one side, papilledema on the other side. Optic atrophy on one side and papilledema on the other side. So it is a feature of it has the feature of unilateral papilledema. So optic atrophy on one side and papilledema on the other side, this is Foster-Kennedy syndrome. It is seen in olfactory lobe tumors. Seen in olfactory lobe tumors, one-sided optic atrophy, other side papilledema. Mizuo phenomenon is seen in Oguchi's disease. Oguchi's disease is congenital stationary night blindness. It is congenital stationary night blindness. CSNB. CSNB is congenital stationary night blindness. Limbal dermoid is seen in Goldenhaar syndrome. Shield ulcer, where is it seen? Where is shield ulcer seen? Where is shield ulcer seen? Correct. It is seen in VKC. And which ulcer is seen in flictanular conjunctivitis? Which ulcer is seen in flictanular conjunctivitis? Correct. Fascicular ulcer. Fascicular ulcer is seen in flictanular conjunctivitis. Fascicular ulcer is seen in flictanular conjunctivitis. Okay. Now, there is a question, what is Mizuo phenomenon? Mizuo phenomenon is seen in Oguchi's disease, where the fundus gets a golden yellow color under bright light. If you see the fundus in bright light, it appears golden yellow. That is called as Mizuo phenomenon. So golden yellow color of the fundus under light adapted conditions. Golden yellow color of the fundus under light adapted conditions. That is Mizuo. Question 13. True about ocular electrophysiology is VEP is affected in disorders of the optic nerve. Pattern ERG is affected in Stargardt's disease, but flash ERG is normal. EOG is diagnostic for Best's disease. The B wave of flash ERG arises from photoreceptors. Ardence ratio is a measure of VEP. Okay, I will not give you the answers. Let us discuss the options. Tell me, VEP is affected in disorders of optic nerve. Is this correct? Is it correct or not? It is correct. Visual evoked potential, it helps to evaluate the entire visual pathway, mainly the optic nerve. It helps to evaluate the entire visual pathway, mainly the optic nerve. So this is correct. Option 3, EOG is diagnostic in Best's disease. Is this correct? EOG is diagnostic in Best's disease. Correct. EOG is the diagnostic test for Best's disease. Option 5, Ardence ratio is a measure of VEP. Is it correct? Ardence ratio is a measure in, it is a measure of EOG, not VEP. Ardence ratio is a measure of EOG. It is not a measure of VEP. Tell me, which wave is a measure of VEP? Which wave is the measure of VEP? Which wave is a measure of VEP? Very good. It is P100 wave. It is P100 wave. P100 wave is the measure of VEP. So VEP is meant for disorders of the visual pathway, mainly the optic nerve. The wave here is P100 wave. EOG is meant for Best's disease and the measure is Ardence ratio. Look at option 4. The B wave of ERG arises from photoreceptor. Is it correct? Is this option correct? No. The B wave arises from right. The B wave arises from the bipolar cells. The B wave arises from the bipolar cells. Which wave arises from the photoreceptors? Which wave arises from the photoreceptors? Right. It is the A wave which arises from the photoreceptors. The A wave of ERG arises from the photoreceptors, not the B wave. Okay. Now, I'll just go over this and I'll come back to this. See, the normal ERG that we do is called as the flash ERG, where you stimulate the eye with light and you get 3 waves, A, B, and C. So there is a down wave called A wave. This is A, this is B, and there is a small wave called C. So this A wave is from photoreceptor, B wave is from the bipolar cells, and C wave is from the RPE. Now this flash ERG, this is useful for generalized retinal pathologies when the whole retina is affected, like in retinitis pigmentosa. Okay, but if you have a localized disease, which is localized to only the macula or only to one part of the retina, it will not be identified in the flash ERG. So if you have a disease which is localized only to the macula, then you must use an ERG called as pattern ERG. So if you have a macular pathology, you use pattern ERG. And if you have a localized pathology somewhere else, you use a multifocal ERG. So for generalized retinal pathologies, I will use flash ERG. For macular pathologies, I will use a pattern ERG. And for localized retinal pathologies, I will use a multifocal ERG. Okay. So now tell me, in case of Stargardt's disease, this is Stargardt's disease. This pathology is localized to the macula only to the macula. So which should I use? I should use a pattern ERG, because the flash ERG will not be able to pick this up. Okay. So pattern ERG is used for Stargardt's disease. So now let us look at the options. So first option, visual evoked potential is affected in disorders of optic nerve is correct. Pattern ERG is affected in Stargardt's, but flash ERG is normal. This is also correct. EOG is diagnostics for Best disease is correct. B wave arises from photoreceptor is wrong, because B wave arises from bipolar cells. And Ardence ratio is a measure of BP is wrong, because Ardence ratio is a measure of EOG. And P100 is a measure of P. Okay. So the correct options are 1, 2, and 3. This is what Best disease looks like, and this is what Stargardt's looks like. Tell me, what is the substance deposited in Best disease? What is the substance deposited in Best disease? Correct. It is lipofuscin. Okay. Question 14. The center for the vertical gaze is in the pons. We have to identify the true statements. Steele-Richardson syndrome is a down gaze palsy. 1.5 syndrome is caused by lesion in PPRF and MLF of the same side. Horizontal saccades are controlled by the contralateral front lobe. Convergence is lost in INO. Tell me what are the correct options. Tell me what are the correct options. Okay, I think all of you have identified option 3 as the correct option. That is 1.5 syndrome is caused by lesion of PPL, RF and MLF of the same side. So there are 3 options which are correct. So before this, see, I think most of you know about, the horizontal gazes perfectly. What we don't read is the conjugate movements, and we don't read the vertical gaze. So those 2 things I'll tell you, then we'll come back to this question. Horizontal gazes, most of us know. Now see, horizontal conjugate movements are of 2 types, saccades and pursuits. Saccades are the fast movement. So if I move my eye like this, this is saccade. But if I move my eye slowly like this from one end to the other, that is a pursuit. So conjugate movements, the rapid ones are the saccades and the slow ones are the pursuits. Now important to remember for exam, the saccades are controlled by the contralateral frontal lobe, whereas the pursuits are controlled by ipsilateral occipital lobe. So saccades are controlled by the contralateral frontal lobe, pursuits are controlled by ipsilateral occipital lobe. Okay, so now let me tell you about the vertical gaze. Horizontal gaze, all of you know. The vertical gaze. The center for the vertical gaze is located in the midbrain. Where is the center for the horizontal gaze? Where is the center for the horizontal gaze? It is in the pons, correct. It is in the parapontine reticular formation, that is PPRF. So vertical gaze is located, the center is in the midbrain. Horizontal gaze is in the PPRF. Okay, we all of us know the horizontal gaze palsies. I wanted to tell you about the vertical gaze palsies. So there are 2 vertical gaze palsies, Perinaud's and Steele-Richardson syndrome. Perinaud syndrome and Steele-Richardson syndrome. Now Perinaud's is an upgaze palsy. And it is also associated with pupillary light near dissociation. Very, very important. Tell me another condition associated with pupillary light near dissociation. Tell me another condition associated with pupillary light near dissociation. Very good. It is Argyll-Robertson pupil. Argyll-Robertson pupil. Argyll-Robertson pupil. So, Perinaud syndrome is an upgaze palsy and it is also associated with pupillary light near dissociation. Steele-Richardson syndrome, this is basically a variant of Parkinsonism and it is associated with downgaze palsy. So Steele-Richardson syndrome is associated with downgaze palsy and Parkinsonism. So Perinaud's is an upgaze palsy with pupillary light near dissociation. Steele-Richardson is a downgaze palsy and it is a variant of Parkinsonism. And the center for the vertical gaze is in the midbrain. Okay. Now with this in mind, let me go back to the question. Center for the vertical gaze is in the pons. Center for the vertical gaze is in the pons. Is it correct or wrong? It is wrong. Why? Because the center for the vertical gaze, where is it located? Center for the vertical gaze is in the midbrain. Correct. Steele-Richardson syndrome, we just learned it is a downgaze palsy associated with Parkinsonism. So it is correct. What did we learn is the upgaze palsy? What is the upgaze palsy? It is Perinaud's. Correct. 1.5 syndrome is caused by lesion of PPRF and MLF of the same site. Correct. Now I'll ask you two questions just to see if you remember horizontal gaze palsy. Lesion of only PPRF causes what? Lesion of only PPRF causes what? Lesion of only PPRF causes horizontal gaze palsy. Correct. Lesion of only PPRF causes horizontal gaze palsy. And lesion of MLF causes? Lesion of MLF causes? Correct. It causes INO. What type of nystagmus is seen in INO? We just learned. What type of nystagmus is seen in INO? We just learned. Ataxic nystagmus. Correct. Ataxic nystagmus is seen in INO. So option 2 is correct. 1.5 syndrome is caused by lesion of PPRF and MLF of the same side. Horizontal saccades are controlled by contralateral frontal lobe. This is also correct. We just learned. And pursuits are controlled by which lobe? Pursuits are controlled by which lobe? Pursuits are controlled by, correct, ipsilateral occipital lobe. Now the last option. Convergence is lost in I and O. This is wrong because the convergence pathway is a part of which pathway? Convergence is a part of which pathway? This you have to think and tell me. It's a part of which reflex? It is a part of which reflex? Correct. It's a part of the near reflex. It's a part of the near reflex. It is not a part of the horizontal gaze pathway. Okay. So INO is a problem of the horizontal gaze pathway. It is not a problem of the near reflex. And convergence is a part of the near reflex. So convergence will not be affected in INO. This is very, very important to remember. Convergence is a part of the near reflex pathway. And so convergence remains unaffected in INO. INO is a problem of the horizontal gaze pathway. And so in INO, when you are looking to the other side, this side medial rectus will not move. But when you are trying to converge, the medial rectus of both the eyes will move. So convergence is preserved in INO. It is not lost. So the correct options are 2, 3, and 4. Okay. Now for the last question. The false statement about color vision is or are. Magnocellular part of the LGB is involved. Red-green deficiency is a feature of optic nerve diseases except glaucoma. First plate of Ishihara is read by everyone. Achromatopsia is caused by complete absence of cones. Congenital color blindness has X-linked dominant inheritance. What are the false statements? Everybody has been able to identify one option, but the second option, okay, I'll give you the answers. The answer is 1 and 5 are wrong. Magnocellular part of the LGB is involved is wrong. Why is it wrong? Which part of the LGB is involved? Which part of the LGB is involved? Correct. Parvocellular part. The lateral geniculate body has two parts, magnocellular and parvocellular. The parvocellular part is a part of color vision. Magnocellular is associated with what? Magnocellular is associated with motion. It is associated with moving objects or motion. So M for M. Magnocellular is meant for detecting motion. Parvocellular part of LGB is responsible for color vision. So the first option is wrong. Red-green deficiency is a feature of optic nerve diseases except glaucoma is correct. All optic nerve diseases except glaucoma present with red-green deficiency. Only glaucoma presents with what? Glaucoma presents with, yes, blue. Blue-yellow deficiency is seen in glaucoma. So all optic nerve diseases present with red-green deficiency except glaucoma. The first plate of Ishihara can be read by everyone. This is correct because the first plate is not a testing plate. It is a demonstration plate. The first plate is a demonstration plate. It is meant to show the patient what this test is going to be like. So the first plate is read by everyone. Achromatopsia, the name itself tells you, it means that he cannot detect any colors, which means that there is absence of cones. So all cones are absent. That is why achromatopsia. And congenital color blindness has X-linked dominant inheritance. This is wrong. Why? Because inheritance is X-linked recessive. Correct. So this was actually an easy question. Congenital color blindness has X-linked recessive inheritance, not dominant. So the false options are 1 and 5. The other options are correct. So these are the questions we had for today's. I will share the important slides with you because I know that many of you would not have been able to copy down. I'll share the questions with the correct options and the important slides with, I will send it to the admin and they will share it with you. Okay. So I'm actually glad that I got so many correct answers because the paper was actually pretty difficult. And we had a fruitful session because I did not expect so many of you to get so many options correct. And I'm really glad. So thank you very much for joining this discussion. And for daily MCQ discussions, sorry, you can just join this group. Just give me a minute. Just put on the last slide. You can join my Facebook group or the Telegram group where you can ask any further doubts that we may have. So you can search for it on Facebook or on Telegram and you'll be able to find it. Okay. So thank you very much. Thank you, Dr. Arun.
Thank you, ma'am. Thank you so much, ma'am.
Okay.